Well, welcome to this disease state review on atrial fibrillation. In this session, I'm going to focus on what all of us need to know about AFib. Who gets it? Basically the epidemiology, what's going wrong, the patho, and how it presents, is diagnosed and even managed. Atrial fibrillation is not only the most common sustained arrhythmia, but it often requires a layered, guideline-driven approach to meaningfully improve our symptoms, reduce hospitalizations, and obviously to help our patients live longer lives. Hey guys, I'm Dr. Busti, and thanks for joining me on This Is Why, a show dedicated in helping you to understand the why behind the diseases that we all see every day in clinical practice. When you understand the why, the decisions about how, especially in both the acute and long-term care, become faster, safer, and more consistent. All right, so one of the things that we're going to address in this topic, okay, we are going to address the chronic, stable, outpatient perspective, but we're also going to address what happens when the patient presents or has acute onset, whether that's for the first time diagnosis or presenting to you with a known chronic AFib and they've exacerbated it, okay? So what that entails is we're going to hit some background information, cover the pathophysiology in a simple, basic way, make sure we understand risk factors, clinical presentations, workup and evaluation that leads to the diagnosis, some of the potential complications associated with AFib, and then dive very quickly into how do you treat these patients, strategies, certain comorbidities, what do you use, what do you avoid in certain patients, and then we'll wrap it up. Okay, guys? So it is the most common sustained arrhythmia in the United States, okay? Now, that, if you look at the epidemiology, again, 2010, there was approximately 5.2 million patients, and that prevalence is expected to increase in 2030 up to 12 million, okay, or over, right? So that's very relevant. And when you consider the aging population and who gets it, patients over the age of 85 are at greater risk of seeing that. Why? Because we're keeping people alive longer. We're managing comorbidities with a greater degree, and that means they develop many of the comorbidities and risk factors that actually worsen and propagate this disease. Approximately 1/3 of hospitalizations are related to it. So this points to the reality of why this particular topic is so important. Now, terminology has shifted over the course of time. I mean, as the disease is understood, as we categorize patients into the different types, terms have evolved and gone away. Many of these that are up here are abandoned: chronic AFib, clinical AFib, lone AFib, valvular and non-valvular. I mean, some of this stuff is confusing. And so the experts, guidelines, we've been trying to work on kind of getting rid of that and starting to shape it. I'm going to point you to a table that I put together for you that actually walks you through all of those names. Many of those listed here: paroxysmal AFib, persistent, long-standing persistent AFib, and then eventually evolving into permanent AFib. So those are some of the terms that we're going to see again in this lecture, but it's important that you know that type of information. Now, next what I'd like to dive into is the pathophysiology underlying atrial fibrillation. And in order for us to understand that, it's always really good to just take a moment and recognize what is normal look like, and then what does abnormal look like, and why does it happen, okay? So one of the things you're going to see here in this particular diagram, but also small animation, is how the heart is supposed to normally beat and the electrical current moving through it from the SA node, which is over here, okay, to the AV node, right at this area here, and then it moves down into the septum and the bundle, and up through the ventricles. And so you can see that here, that the normal heart rate that is contracting, okay, shows a coordinated effort where the upper chambers are pushing the blood down into the lower chambers that then push it out to the heart. It's very coordinated response, okay? That is, generates a normal sinus rhythm on the EKG. Now, what about the abnormal, okay? You're going to see the atrium starting to fire in all of these random locations, and when it does that, there's lack of coordination back into the ventricles, and so there's this sort of lack of forward flow that I was mentioning before, okay? And so you can see that here, where there could be up to 300 beats in the atrium that then finally some of them make it into the ventricle. And it's important to recognize that not all of those make it into the ventricle. You don't want that, because if you had 300 electrical currents all arriving at the AV node and they all went through it, then the patient's pulse would be as high as 300 potentially. That's obviously not going to be compatible with coronary perfusion to the coronaries or your brain, and patients probably are going to be unresponsive in that situation. So the AV node helps to regulate some of the flow from the atrium through there. So it's about 2 to 1, right? So that's if you especially in RVR kind of cases. And what we see in that situation is that if there's 300 in the atrium, then only half of them make it through, then the rate is about 150. Well, when patients are in AFib with RVR, that's about the rate that we see. Now, yes, it gives or take in a bubble about 10 beats per minute, but the reality is that is what you should be seeing. Okay, so one of the first things that we need to talk about is what happens to the heart, okay? So one of the things I'd like to walk through is some of the structural changes. There's a lot of things going on in the body when patients develop either chronic or acute AFib. One is that the renin, angiotensin, aldosterone system gets activated. In doing that, causes remodeling. That remodeling causes structural changes that lead to also electrical changes. You have stimulation of repair mechanisms, that turn on this repair process and cause a remodeling. We have metabolic abnormalities that are occurring inside the tissue from mitochondrial dysfunction. We have activation of inflammation, promotion of oxidative stress, development of autonomic dysfunction. All of this, guys, results in atrial enlargement, hypertrophy, and overall cardiomegaly. And sometimes we can see that on x-rays. Sometimes we see it on our EKGs in the way that the current looks. Okay, now what does those structural changes do to the electrical physiologic effects of the heart? Well, one is the autonomic nervous system results in hyperinnervation due to these structural changes. And that's why when you saw on the AFib, you saw firing all over the place happening, and they're all trying to converge into that AV node, okay? And so what ends up happening is the irritability and these structural changes create those ectopic foci and re-entry circuits that occur. And so that's where you get that very rapid atrial pulse that's way beyond what the normal SA node would typically try to do, and thankfully the AV node not allowing all those to come through, okay? Now, the next thing that happens is also what is going on with these ectopic foci. They form throughout the atrium, but the ones that we get really concerned about are the ones in the area of the entry into the pulmonary artery. That area that starts to stretch, okay, that is where some of these abnormals, intermittent conductions really start to then become more permanent, right? And this is what overall, when you factor in all of these things, the remodeling, the ectopic foci, the rapid movement, the ineffective atrial kick that fills the ventricle, that says the ventricle is contracting and the cardiac output changes, all of that is being impacted. So you see a lower cardiac output that then decreases perfusion to other organs and things like not only your brain, but also your kidneys. And that then in turns on, the kidneys perceive that, and they turn on and release the substance renin that turns on the RAS system that I mentioned just a few minutes ago, that then creates not only reabsorption of sodium and water, that increases plasma volume, that will stretch the atrium and put more workload on the heart, but also causes the remodeling. Angiotensin II is a potent mitogen, and when it's activated in high concentrations, it's going to facilitate all that structural change. Again, all of that leads to an impairment of forward flow that favors stasis also in the atrium, that can lead to clotting, but also lowers the cardiac output. And that leads to stasis and the cardiac lowering of the cardiac output that leads to that formation of a thrombus is what puts the patient at risk for stroke. So let's now transition from the abnormal patho, now that we understand some of those basic mechanisms, and let's move into what are some of the risk factors. And we want to consider risk factors that are modifiable, non-modifiable, and that things that are secondary contributors. One of the things that I've put together for you and is available at thisiswhy.health for free as a download. You can use them for study tools, share them with your friends, colleagues. If you're a preceptor faculty, feel free to use them in your lectures, whatever, for teaching. Try to put together some of these things that summarize all this. So if what you see on this particular table is on the left side, the modifiable risk factors, non-modifiable risk factors, and then the contributors to secondary AFib. And then on the right side are just a few notes, okay? So when we think about modifiable risk factors, think head and toes, okay, body parts. Head being heart failure, exercise, arterial hypertension, and then D, diabetes. What about toes? Again, things you can modify. Tobacco use, obesity, ethanol, sleep, all of that becomes important. And then you think about the other, valvular disease, chronic kidney disease, patients with coronary artery disease, all of those can be influenced and are modifiable. Non-modifiable are things like the age of the patient, their genetics, and their gender, okay? Contributors of secondary AFib include things that are listed there like acute myocardial infarctions, cardiac surgery, especially during the post-op period, anything that irritates, inflames the myocardium can make the myocardium more irritable. So that's why myocarditis, pericarditis. That's inflammation of the myocardium, myocarditis, inflammation, irritation of the pericardium, pericarditis. Pulmonary embolisms. Okay, remember those clots lodge into the pulmonary artery. Well, that puts pressure that backs up into that right ventricle and eventually into the right atrium. That stretches the right atrium, and the more stretching from fluid, too much volume, or lack of forward flow, then increases the irritability in those ectopic foci that can happen, especially around that entry to the pulmonary artery. And then lastly is drug-induced hyperthyroid states, even by using levothyroxine itself, which is obviously the treatment of hypothyroidism. Too much of it can lead to a state of atrial fibrillation, which is one of the reasons why we check it, okay? All right, guys, now let's move into the clinical presentation. What kind of signs, symptoms, when you're doing an exam, what do you need to be thinking about, right? So again, in a common disease state review, we want to make sure that we address these. And so what I, again, have put together as another table on the left side are some of those signs and symptoms that patients will report or that you'll see, and then of course some details on the right side. I'm not going to read all that to you, and those of you that are joining us on our podcast channels, again, these are available for you to see at thisiswhy.health, but I'm going to try to walk you through it here, okay, again. So we have irregular pulse. So the pulse is not a very regular rhythm. It's irregularly irregular, okay? So you palpate the radial pulse, palpate the carotid, or you're just listening and auscultating and palpating at the same time, there is going to be this erratic beating and palpation that you can actually feel. What about palpitations? Those are typically ectopic foci, premature atrial contractions, right? PACs are what we call those. Patients starting to show the early signs of irritability, ectopic foci that didn't really make it yet. Okay, those are some of the red flags. Shortness of breath. Remember, you're not getting good forward flow. Cardiac output is compromised. So patients are going to start backing up. And so that can lead to shortness of breath, especially when they have other underlying comorbidities that back up into the lungs, that back up into the right ventricle, that back up into the right atrium, right? Fluid overload, heart failure, classic, right? Dizziness, lightheaded. This is typically when we start seeing patients in rapid ventricular response. So those 300 beats, ectopic foci, going down the atrium and hitting the AV node, and some of them are making it through. Well, if they start going through faster, right, then what ends up happening is again, patient feels it, but they are having lower cardiac stroke volumes and cardiac outputs, and that makes them dizzy, especially with some degree of exertion and positional changes in position. Fatigue, well, your efficiency of the pump is compromised. And so as a result of that, you are not effective. Your metabolic demands can't be met as easily. And then lastly, your exercise tolerance for the same reasons. This stuff is not rocket science. If you just stop and think about the mechanics and the underlying pathophysiology, well, it starts to make perfect sense, okay? Now, let's now move into that workup. So you got patients presenting, you understand the pathophysiology, you're seeing a pattern of association, you may run a few tests. You want to treat the underlying problem, but you also want to diagnose the problem in a correct way. So let's dive into that. So this particular table offers you a summary of breaks down some of the diagnostic information by vital signs, labs, other tests that we would do, okay? So I've broken it up into two different tables. This table here is one of vital signs and labs, and then there's what you do at baseline in the vital signs versus what you might do on a long-term intermittent basis. And one of the things that you see at the very early on in the baseline is, yes, you're going to do things like get their temperature, check the pulse, the blood pressure, the pulse ox. Yes, all of those things need to be done. But what you also see is the weight, the waist circumference, and the BMI, because obesity is one of those kind of secondary contributors to it. We see this show up actually in some of our risk factor tools that I'm going to cover later on, the CHADS-VASc score, HAS-BLED. These things use some of these risk factors and patient-specific characteristics to guide us. And so that's why that's there. Next is on the labs, you see things like electrolytes, making sure the patient is anemic, looking for, and when I talk about electrolytes, I'm not just talking about sodium and potassium, but don't forget about your calcium, magnesium, which remember you have to order a magnesium separate to the other labs. And the reason you have to do that is because it's not part of a CMP or BMP. So make sure you add those things in, because remember, if someone is hypokalemic, you want to make sure that they're not hypomagnesiemic. Well, both of those electrolytes, including sodium and calcium, can all lead to irritability because the cardiac myocytes use those electrolytes to facilitate the electrical current moving through them. So we don't want to create a milieu that favors that, and electrolyte abnormalities hands down. TSH, thyroid stimulating hormone, okay? That particular thing needs to be assessed, especially at baseline or in an acute exacerbation. Why is this patient in acute AFib or RVR? You need to consider that. Now you'll see things listed here like BNP, okay, or pro-BNP. Those are markers of obviously fluid volume, and that reflects the stretching of the heart. You may have heard that now for the third or fourth time. When the atrium gets stretched and there's remodeling starting to happen, that stretching makes it irritable. It also causes remodeling. So when we see fluid elevations or fluid overload, and in my world, in the emergency department, many times their acute decompensation of AFib is due to fluid overload. There's an acute stretching from too much fluid accumulation, and that throws them into AFib with RVR. And this has even happened in patients who have gone back into normal sinus rhythm and now flip back into AFib. Sometimes just treating the fluid fixes the problem. That's why this matters. Now, why would you get troponin? Well, again, if you're having a heart attack, that will make the myocardium irritable, right? Just like CABG or open heart surgery, just like myocarditis, pericarditis. And remember, the troponin can go up in myocarditis, but it can also go up in a myocardial infarction, right? So we don't forget this. Plus, when you have AFib, you're increasing oxygen demand, you're making a pump less efficient and effective. Well, that may compromise the metabolic needs of that patient, and that may cause them to go into a heart attack. Remember, diseased hearts can't sustain pulses in the 150s plus for long periods of time. The lipid panel here is really more about a baseline, treating those underlying causes associated with their diseases. And then when you see long-term, just don't forget to intermittently check the thyroid, intermittently check the magnesium, especially if these patients are on diuretics, where those things can be compromised. Now, the next set of things to consider are imaging and then this miscellaneous, okay, EKG. Right? That's probably this, seems like the obvious first line one that you would do. But chest radiographs, especially if you can do a posterior anterior view, that means you usually have to take them into the radiology department and they put their chest up against the plate and the x-ray beams are being shot out behind through their back to the front. Why? Because it gives us a great representation and a more accurate representation of the cardiac silhouette. Also, if there's fluid, pulmonary edema, pleural effusions, vascular markings, but we see that cardiac silhouette to see if there's evidence of cardiac enlargement. Are the atrium swelling? Is the cardiac silhouette showing evidence concern for cardiomegaly? Remember, a portable AP, anterior posterior, where the plate is behind me, can cause a false elevation or enlargement of the cardiac silhouette. But we want to look out for those things, and we want to look for other causes, even pneumonia, even a collapsed lung like a pneumothorax, okay? So those things matter. Echocardiogram, that is going to be very helpful at seeing the size, actually measuring it, looking at the valves and seeing if they're opening and closing correctly and there's not regurgitation. It also helps us to see the motion and the movement of the myocardium as it's literally beating. And now we can do bedside ultrasounds, even now connected to a phone or an iPad. Now they're not as good as obviously a formal, but you can do quick assessments and just see what the heart is doing right there, okay? It's actually quite amazing. Why would you do a CTA chest? CTA is for a CT scan that's looking at with contrast to look for the presence of a pulmonary embolism. Again, the pulmonary artery is occluded. That goes back to the patho. That backs up through the pulmonary artery into the right ventricle and eventually stretches the right atrium. So an acute PE can throw someone into acute AFib or exacerbate their underlying AFib to go into RVR. Well, you can imagine if you have a PE and you go into AFib with RVR, now you got two whammies affecting the cardiac output and stroke volumes. That's not good. The patient can be very unstable, hemodynamically unstable, where you have to intervene sooner than later. I'll mention that here in just a minute. And then lastly is the EKG, the most common way that we assess it. Yes, but I want you to know how to palpate the radial carotid pulse and listen. You should be able to discern that clinically. But let's take a look at what that looks like. So this is an example of the normal sinus rhythm, okay? You see a very clear P wave followed by a QRS and a T wave. And when you were to, if you were to march these out and measure them, each of the R's here, you would see that they're equal. They're not changing in their duration, even though physiologically there can be subtle variations from inspiration and expiration. But overall, they're very regular, and you can discern this P wave right here with every QRS. That's key, okay? When you look at or you add in and compare it with atrial fibrillation, okay, now you don't see that discernible P wave with every QRS. What you see are these little scattered lines, almost like motion artifact present. And in that motion artifact, there's not good squeeze. Remember, you can have up to 300 beats in the atrium. They're not all going to show up. Some of them are buried inside of the QRS, which is reflective of the ventricle contracting. Okay? So this is classic irregular rhythm, and you know that because you can see here that the distances are not the same. It's varying, and you have no discernible P waves. That is classic. You just got to know that. Okay, now it's time to dive into the diagnosis. We're concerned, we got enough information to have AFib. Now, where are they at in the evolution? That's what's important to consider next is, are they in AFib with RVR? If not, where are they at? Okay, they have permanent AFib, or is it paroxysmal AFib? Those terms that I mentioned at the beginning of the presentation, okay? So you can see that here on this table, again, available at thisiswhy.health for free download. And you see what I have on the top part is the staging and evolution. All diseases have an evolution, right? And so we've been able to codify that over time. And so what I appreciate about this is understanding the progression so that you can intervene at the right time, so that you don't waste so much time that now the patient has lost time and the disease is progression. Same thing with heart failure, right? Uncontrolled hypertension. All these things matter, so we will try to find them earlier than later. And so you can see that it goes from stage 1, 2, 3A, B, C, D, and then eventually to 4. I know that 3A through 3D, those are the ones that are really kind of splitting hairs, but it really have to do with whether or not, in part, ablation was done, and also relates to the duration. Okay? Now, there's descriptors there. Okay? So we have pre-AFib and stage 2. Those are patients who are predisposed to AFib, right? So you have observed structural changes, probably on an echo. We might see it on a PA, chest radiograph. That's where your monitoring needs to be heightened. You need to be a little bit more concerned, right? Again, before they convert and it becomes more consistent. Paroxysmal at 3A here is intermittent, self-terminates or spontaneously converts back. It doesn't last more than 7 days, and most end less than 24 hours. Okay? And then as you go from 3B, it just lasts longer and requires treatment. 3C, the duration is now more continuous, over 12 months. 3D is successful ablation, which is one of our non-pharmacologic interventions that we can do, and we'll talk about it towards the end. And then if they're left untreated, will become permanent. Cardioversion is failing. No additional temps are going to be needed to try to gain rhythm control. You're just going to do what you can to control rate and or rhythm with medication. Now, the pillars of atrial fibrillation management is in the bottom part of this table. And there's the 4 A's, access to all aspects of care for everyone. Again, just reminding us of that importance. And then SOS, S standing for stroke assessment. The next is O, optimize all modifiable risk factors. And we talked about head and toes, right? That important, those mnemonics to remind us of the core risk factors that we can change, especially those that are modified. modifiable. And then lastly in SOS is the symptom management, which is really when they start to have more paroxysmal, that 3A, right, where we're treating then the rhythm and or rate control, and it influences by the amount of burden that they have. Okay, so that's a lot, guys. We've talked about background. We've talked about what causes AFib, the pathophysiology, risk factors, how they present, some of the things that we do in the workup and the diagnosis. Why does this all matter? Remember again the why behind what we do, because we're trying to prevent complications. And those complications are listed here in this table. I put there the increased risk of how many fold we see arise. Heart failure, stroke. Those are hands down the two biggest things you need to be worried about. Again, heart failure, low cardiac output. What did we talk about? Impaired forward flow. We're not getting good perfusion to the peripheral organs like the kidneys. Turning on RAS. We know RAS is a problem in heart failure. We have drugs like ACE inhibitors and ARBs and diuretics and mineralocorticoid receptor antagonists. All these drugs to try to regulate and control renin, angiotensin, aldosterone system. So it gets revved up because heart failure is a risk. Fivefold, stroke. It's cardioembolic. Remember that stasis in the atrium allows the blood to sit there and coagulate. Verkyle's triad, no different than in the deep veins of your leg after a surgery. And it finally gets a good contraction, or you might flip into normal sinus rhythm spontaneously, like in paroxysmal AFib. And you get a good atrial contraction, and that moves the thrombus from the atrium now into the ventricle and kicks it out into the systemic circulation. It can go to your brain. That's cardioembolic stroke. But guess what, guys? It can go other places. It can go down the aorta and go into the superior mesenteric artery and occlude your GI tract. Yeah. Acute infarct of your small intestine. Not a good thing. Severe abdominal pain like you've never seen. If that bowel dies, the patient's going to die. No different than the brain. Right? It can get into one of the renal arteries and basically infarct that. It can get down into the vasculature of the lower extremities and infarct that, especially in patients with peripheral arterial disease. This stuff is very real. So don't just automatically think of cardioembolic stroke, but keep in mind some of these other things. And as I mentioned, peripheral arterial disease down here, the reason it matters is because they have clogged plumbing already. Okay? So you see sudden cardiac death from the remodeling. You see chronic kidney disease over time from poor perfusion. You see that risk of myocardial infarction because of increased oxygen demands. You're just setting up a milieu for worsening mortality. Right? So we've got to be able to target these and recognize these complications so that you're aggressive at it. Okay? Now, we're going to pivot to the treatment. Okay? And I'm going to walk you through the general considerations, but I also want you to recognize the difference between acute and chronic. And again, guys, I recognize that some of you may practice in the outpatient environment and you don't care about what we do in the emergency department or the ICU or the hospital. But the reality is our patients as a medical team go in and out of the hospital, and we need to understand what each other are doing and what are our purposes and goals in managing these patients so that we can provide that continuity in treating those modifiable and trying to do what we can for secondary contributors of AFib. Okay? All right. So first is recognizing acute versus chronic. Okay? These are some of our treatment considerations. Number two is our treatment goals. Number three, which we've already discussed, is the treatment of modifiable risk factors. And then that leads us to some of our strategies for heart rate, especially when the heart is beating too fast from those atrial contractions making it through, to the rhythm, okay? And then non-pharmacologic, and also consideration of anticoagulation. You heard me talk about the risk of VTE, right? Cardioembolic strokes. Well, if patients end up having that, that's why we do the CHADS-VASc, which I'll talk about here in a minute. How do you know who to start on anticoagulation in the acute, but also the chronic outpatient AFib patient? Let's make sure we address those. But let's first talk about what are our ultimate treatment goals. Heart rate, we desire it to be between 80 and 100. Why is that? Again, oxygen demand, the efficiency of the pump. Now in AFib with RVR, we will tolerate up, higher above 100, but we really want it to stay between 100 and 110 in the acute, and then eventually get it to 80 to 100. We obviously want to reduce the risk of heart failure, stroke, and death. And then we also want to reduce their symptoms. Patients want to feel better. This is their quality of life issue that makes them then want to come to the clinic or come to the hospital or emergency department, that then takes up resources. So by managing patients well, keeping them symptomatically controlled allows us to not only improve their quality of life, but also the burden on the healthcare system. Now, when we start talking about and start stepping into strategies, there's the rate control strategy, and then there's the rhythm control strategy. There's a lot of things that go into that, and I'm going to start diving into that slowly, and I'm going to talk about it in the context of acute and chronic. But follow me here. Factors that influence this is the level of acuity of the patient, how we're going to treat them, and the severity of that heart rate. Are they 80 to 100, or are they 150 and having chest pain? Okay. The number and severity of their symptoms. How many comorbid conditions do they have? The medication profile that they already have, because that can lead to potential adverse drug events and drug interactions when we start adding in more drugs. We're going to see here in a minute, like diltiazem is an inhibitor of cytochrome P450-3A4. It can cause drug interactions with certain lipid-lowering drugs. It may interfere with anticoagulants. We need to be aware of these things so that we don't cause secondary problems in our patients that then lead to more utilization of the healthcare system. And then the other thing is patient-specific factors. So we need a balanced, individualized approach. Okay? So when you look at charts like in tables like this, which is about rate versus rhythm, what are some of the characteristics that help you to decide which one you will do, even acutely and in the long term? Because remember, what we start sometimes in the emergency department or the hospital is what we'll send the patient home on. So that means for those of you in the outpatient environment, you're going to decide, do I keep that, or do I modify the dose and adjust it, or change it altogether? Okay, so there are things that guide us, and we need to try to find the best thing for our patients. And that's why when you look at over here on the left, it says at the top, patient factors. And that may be also their preference. What do they prefer? Okay, so you see that listed here. Do they prefer rate control after they hear the pros and cons, or they prefer rhythm control? So the middle column here is talking about the variable. So patient choice is that first one. Do they favor one over the other? Have they heard something over one over the other? You see that older patients tend to do better and we tend to favor rate control. Why? Because antiarrhythmics have a lot of side effects, a lot of potential problems. You're going to see that here in just a second. So they are typically held for younger patients. Okay? Patients with a longer history of atrial fibrillation are going to tend to do better on rate control, because the rhythm is not probably going to convert the longer they have it. It becomes more permanent, making it harder for you to convert them out of it. So patients with a shorter history might be able to be pharmacologically converted or controlled with an antiarrhythmic agent, assuming they don't have certain contraindications. Those who have fewer symptoms are going to do better on rate control. So that's how you use this, and you kind of guide. It's a guide. They're not absolutes. Every one of you is going to be a little bit different. You're going to see variability. It needs to be patient-oriented and specific. The next thing to consider is the exam, your physical exam, and the anatomy. That's why the echo, chest x-ray, listening to the patient is so important. So as it relates to rate control, okay, those who have if there's a larger atrium, left ventricular dysfunction, less of it, less atrial GERD, they're going to respond pretty well, right? Whereas if we have a smaller left atrium, more left ventricular dysfunction, all these things, then those patients might, again, these are not absolutes, guys. So don't treat it like that. Sometimes we do that with guidelines, tables like this. It's a guide that kind of helps you to understand what you can do to manage these patients. Now, let's first talk about the acute patient, because they can present to clinic, they can present to the pharmacy, they can present to the ER, and they're like, I've had patients come in saying, hey, my Apple Watch is telling me that I'm an AFib, right? And I'm like, well, let's check your pulse. Oh, you sound like, you feel like it, you're feeling it, your watch says it. It's amazing, right? So it can happen anywhere, and you need to know how to triage that patient appropriately to get them to the right location. So the first question in the acute is, how are they unstable? Because if they are, that drives us to a very important decision I'll talk about in a minute. Our desired heart rate is to be around that less than 110, ideally. In the acute, we want to eventually get them excuse me, to 80 to 100. And then we want to reduce their oxygen demands. We want to increase cardiac output, increase the forward flow, and we want to prevent any secondary complications, okay? Acute kidney injuries, hypoperfusion to other organs, these kind of things can be relevant. We don't want to stimulate a myocardial infarction. And we want to gain control of the underlying etiology. So we got to consider what strategy we're going to use. Now, what you see on these particular slides here is trying to give you rate control, but the assumptions or underlying characteristics of the patient. So in this one, there assumes there is no pre-excitation. That's true for the outpatient as well, by the way. Okay, or WPW, Wolff-Parkinson's-White syndrome. Okay, so no pre-excitation. What is that? Well, basically it's the presence of a delta wave. The delta wave, which I'll point right out right here, you can see the upslope after the P wave. That curvature right there at the beginning of the QRS is a delta wave. And that is a strong indicator of WPW. The reason that matters is because they have accessory pathways that bypass the AV node in the heart that we were talking about earlier. If you bypass the AV node, and when you give an AV nodal blocker, which is a lot of what we do in rate control strategies, you will then allow more potentially of those pulses from the atrium and the ectopic foci to go down through those accessory pathways, bypass the AV node that is serving as a gatekeeper, and then you can accelerate. Yeah, even with an AV nodal blocking drug, you could accelerate their pulse in the acute environment of the hospital or in the outpatient environment. So you want to rule out a pre-excitatory condition in their EKG and the presence of WPW for this reason. Now, if the patient is showing signs and symptoms of hemodynamic instability, their blood pressure is dropping, right? This systolic is typically less than 90. They can't stay awake. They're getting drowsy, or they're saying they're having chest pain. You got to immediately do what is called synchronized cardioversion in that patient. And the reason you're not defibrillating them is because cardioversion is about the timing of where the electrical current is delivered to the patient. We need it to be timed right in cardioversion. We only defibrillate in rhythms like pulseless VTach and VFib. Okay, so you need to understand, that's why it's so important to recognize rhythm strips and how to read a basic EKG. So if you got someone's hemodynamically stable, you need to make them stable. And unfortunately, that many times requires you to do immediate synchronized cardioversion. Please don't get that confused with defibrillation. All right, what about the patient with AFib without heart failure with reduced EF, so they do not have reduced EF, or WPW. Common things: AV nodal blocking drugs, specifically usually parenterally administered. Beta blockers, you know, metoprolol is a great example. Esmolol could be another one. Non-dihydropyridine calcium channel blockers, diltiazem, verapamil. Now, magnesium sulfate is listed there. Why on earth would that be there? Again, it's important to understand why you do what you do. Why would I recommend magnesium infusion? Well, magnesium, remember, is a divalent cation, and it can compete with calcium. And in doing that, it can relax that muscle and prevent it from firing as much, especially at higher doses. Okay, we use it even as a bronchodilator. We use it for acute migraines for the same reasons. Okay, we use it in preeclampsia for similar reasons. All right, alternative agents. So esmolol, verapamil. So if we were going to use verapamil as being a non-dihydropyridine calcium channel blocker, we typically use diltiazem. But verapamil is another option, especially if something isn't available. You want to know what your alternative agents are, and that's why that's there for you to recognize. You know, so how do you choose in that group? Like, okay, Dr. Busti, that's great, I get it. Well, which one do I go with first? I will say that I typically look at the patient's medication profile and what have they been tried on in the past. What are they if they're on a beta blocker, I know they're tolerating beta blockers, I'm going to give them a beta blocker. If they are on diltiazem or verapamil, and so they're on a non-dihydropyridine calcium channel blocker, that guides me to use those. What do I have available in the emergency department or in the hospital? What does the pharmacy have access to, right? Is there a shortage? Those are all the driving factors. The only reason I would reach into MAG is if patients aren't responding to standard treatments, okay? And the only reason I go to esmolol or verapamil is because of basically I don't have access to the other ones. Okay, but now what if the patient has AFib, but they also have heart failure with reduced F, but no WPW, okay? So again, this is a rate control strategy. So parenteral AV nodal blocking drugs, beta blockers. What about calcium channel blockers? Yes, we can do that in patients with no WPW, assuming they can tolerate it. Now, if they had Wolff-Parkinson's White, we would have to be careful. You have to be careful with beta blockers too, but you definitely want to be careful with the calcium channel blockers. Now, why is this really a question here? And why do you see amiodarone being considered and digoxin? Well, remember, these two are going to be reserved with people with structural heart disease. So if you have heart failure with reduced EF, you most likely have underlying heart disease that is contributing to that, okay? Now, calcium channel blockers, we typically avoid in patients with heart failure. Why? Well, that one, they don't facilitate or inhibit remodeling. Number two, they don't protect against sudden cardiac death like beta blockers do. So remember, the autonomic nervous system is pretty intense in heart failure, especially in an acute exacerbation or situation like this. We want to reduce that heart from getting fatigued and flipping even into a ventricular dysrhythmia or having sudden cardiac death, which I shared with you a minute ago was one of the complications, okay? So non-dihydropyridine calcium channel blockers don't have a positive impact. In fact, they have a negative impact in heart failure patients, so we tend to try to avoid them and only use them when nothing else is available or the patient can't tolerate the beta blocker and other drugs. What do you do in the acute phase, RVR, and you want rate control, and you have AFib with RVR plus Wolff-Parkinson's White? This is where procainamide infusions are largely offered, or you'll see them recommended. They have different regimens that you can use, kind of higher dose, faster regimens to administer, and then synchronized electric cardioversion, assuming there's no obvious known clot in the atrium, and you know the duration of how long their symptoms have been going on. So the time of onset of AFib is very important. The presence of comorbidities like heart failure, WPW, is very important. What about also anticoagulation considerations? That is important, the timing. We'll see that here in a minute. But what if you want to go to the rhythm control? So we just talked about procainamide, which is a 1A antiarrhythmic agent. Okay. What about you have patients with atrial fibrillation without heart failure, reduced EF, right? And you want rhythm control. So they don't have, or the assumption in that statement is that they don't have structural heart disease. So in that, you can consider procainamide, amiodarone, ibutylide being your class 3 agents, procainamide being your class 1A agent. What if you do have heart failure with reduced EF? Look here, guys. You see that the class 1 agent's gone. And that's because the risk of QT prolongation and structural heart disease increases that risk, and it's just not worth putting them into torsades and having ventricular dysrhythmia, and then the outcomes are not near as good. So you have limited use in class 3 antiarrhythmic agents, amiodarone being preferred, and not even ibutylide. That's why it matters to understand your patients and your patients' comorbidities. What if they have AFib and with WPW, but no reduced EF? Again, you can consider then procainamide, ibutylide. So you hopefully see that pattern, that the evidence of structural heart disease, cardiomegaly, all those things can negatively impact the patient's not only outcomes, but also the drugs that we can safely use. There is a pill in the pocket option for people that are pretty savvy, got good established care, understand their disease. Propafenone and then flecainide can be used. Sometimes plus or minus a non-dihydropyridine calcium channel blocker can be used in that situation. Now, what about anticoagulation? If I'm going to try to convert somebody with an antiarrhythmic pharmacologically and they go back into sinus rhythm, I need to make sure they don't throw a clot out of that atrium. Or if I synchronize cardiovert them, I need to be thinking about that. Well, who's at risk? Remember that time of onset, the duration of symptoms increases the risk. The more pooling of that blood in the atrium, the greater the risk that blood can coagulate and form a atrial thrombus, that if you shock the heart back into rhythm, or you pharmacologically convert them back into normal sinus rhythm, could throw that thrombus out. So if they have greater than 24 hours of AFib, anticoagulation is recommended for 4 weeks. And I'm not talking about anticoagulation, I'm talking about the use of DOACs or like vitamin K antagonists like warfarin. If it's been less than 24 hours, okay, and they have a low CHADS-VASc score, okay, 0 for men and 1 for women, you can consider a omission of that, okay? Because remember, they probably haven't had enough time. If you have clear, like I knew when it started, I felt it, and you have a clear time interval to it, then that guides you. If you go beyond 24 hours, okay, but you're still within the 48 hours, again, it goes back to that CHADS-VASc score, which we're going to cover here in a minute. You may consider the administering, you do administer, with their CHADS-VASc score is 2 or more with men and greater than 3 in women. Okay, this is where we need a thing like a direct factor 10A inhibitor, something like heparin, unfractionated heparin. You want to give it immediately before you do that pharmacologic or electrical cardioversion. If the CHAD-VASc score is lower, then you can consider, and these are kind of guideline verbiage, if you will, position statement verbiage, debated, not necessarily testable as easily because it's not agreed upon. But you as the clinician, seeing that patient, knowing what's going on, maybe their history may drive you to pick one over the other, but these are some guides to doing that. Now, if you're way over 48 hours and it's unknown, this is where you really want to anticoagulate these patients for at least 3 weeks before. And when I say 3 weeks, I'm talking about therapeutic levels for 3 weeks, okay? So if you start them on warfarin, which sometimes takes a week to get someone into therapeutic range appropriately, that's when your 3 weeks starts at that point, not the day you first give the warfarin. Now, obviously, when you're on a direct thrombin inhibitor or a DOAC or something like that, you can consider that day 1 on those cases. And then after you cardiovert them, whether it's pharmacologic or electrical, okay, then you want to continue the anticoagulation for another 4 weeks, because sometimes the heart and the atrium is stunned and needs that, okay? So that's regardless of the CHA2DS2-VASc score in that situation. What about the chronic patient? So we get them under control, but now we need long-term rate control. Again, assuming no pre-excitation or WPW, beta blockers, non-dihydropyridine calcium channel blockers, diltiazem, verapamil, are going to be your mainstay of treatment for rate control in the chronic outpatient environment. Again, which one do you choose? Well, what if the patient has underlying asthma, COPD with a bronchoreactive component to it? Well, probably beta blockers are not going to be as good for them because of the beta-2 antagonism that can occur that would cause bronchospasm and constriction. Whereas that might be where a calcium channel blocker would be better. But if the patient has underlying heart failure or risk factors for heart failure, we don't probably want to do that. We want to affect remodeling. And that's where beta blockers can be very beneficial in that way. But just be careful with that. Now, what other issues with beta blockers? What if they can get the brain, cause depression, erectile dysfunction, right? Non-dihydropyridine calcium channel blockers can cause constipation, worsening of GERD. They're not benign. None of these drugs, they all have pros and cons. That's why you have to talk to the patient and see what they prefer based on their comorbidities and other symptoms. What about long-term rhythm control? If you're going to do that, there are some driving factors to that strategy, okay? Again, do they have structural heart disease or the presence of left ventricular ejection fractions that are low, typically less than 40%? That's going to influence whether or not you can consider the use of class 1 agents. Okay, so flecainide, propafenone, those are your class 1 agents. In the class 3, you have dofetilide in there, dronetadrone, those drugs being options for patients, again, without left ventricular dysfunction. What about long-term rhythm control? If you've had a prior MI, which would typically lead or suggest that you have cardiovascular disease, you have probably some structural heart disease probably going on there, remodeling that's going to occur after the MI. So again, you want to avoid those class 1 agents. Most people are probably going to use one of these 2 options, amiodarone or dofetilide in that situation. What if they've had a prior MI, but they're class 1 or 2 New York Heart Association heart failure? Well, again, avoiding class 1 agents. If you're going to use a class 3, there's some debate, plus or minus, dronetadrone, maybe. Yeah, but there is some concern about its long-term use in patients with permanent AFib. Remember, that's when it becomes stage 4. Okay? Stage 4 in that evolution. So we want to be very careful in that. So we've been talking about strategies for anticoagulation. We talked about it in the acute environment, but what do you do? And we talked about the use of the CHA2DS2-VASc score. Okay, so this is one of our validated tools that are out there. It's part of the standards of practice, very well used. CHA2DS2-VASc score, if you just break it down, I put it in this table for you. Each one of these has some points with it. So C in the CHADS is the presence of congestive heart failure. And I tried to provide you the descriptors of what that means. okay? Because a lot of times these tools were developed when terminology was different and in the evolution of literature. CHAD being with the letter H, hypertension, and that includes somebody also on treatment. Okay, I've had patients tell me, I said, do you have any medical conditions you're being managed for? No. Well, I take something for blood pressure. Well, you have hypertension. Oh, yeah, I guess so, but I'm on treatment. Well, but you have it. You're on treatment because you have it, right? Patients over the age of 75, diabetes. Again, the DS is stroke. If you've already had a stroke, you see that the points are 2. Age of 75 or greater, 2 points. Okay, so you start adding these up. Okay, if you're age 65 to 74, it's 1 point. Females, 1 point. So the total maximum score is 9 in the CHAD-VASc. And then you come over down here, and I put, based on gender, the scores. And really what it's trying to help you to understand is, do you meet the minimum criteria here for the consideration of anticoagulation? So you see with a male CHAD-VASc score of 1 or a female of 2, that puts them in that consideration. Once they go above 2, for both of them, yeah, you really should be doing it. The benefits in that patient to protect them from against cardioembolic stroke is now better. It exceeds the risk of bleeding from the anticoagulant being used. Now, there are other considerations down here that help you to understand the risk of stroke that I put in here. Things like the increased burden of AFib, its duration, patients with persistent or permanent AFib, obesity, okay, proteinuria, so kidney disease, uncontrolled hypertension, those other things that we talked about before. But what does everybody care about? When you start someone on anticoagulation, it's a blood thinner, right? That's that term that we use to help patients sort of understand it. But what we're really concerned about is the risk for major bleeds. And so there's a number of tools that have evolved. HAS-BLED is one of those tools that is popular. It's not the only one, but it is one. And many times, sometimes the guidelines don't advocate one tool over another. But HAS-BLED helps us to assess the risk of major bleeding when we're going to do that. So if you're like, yes, we should be using anticoagulation, but my patient falls all the time, or my patient is old to the extent that they have poor mobility and their risk of falling and hitting their head is very high. They've already fallen 5 times this year. I mean, I get a lot of patients who've come in the emergency department, falls on anticoagulants, antiplatelet drugs, and I've got to scan their head. I mean, it happens 3 or 4 times a shift, right? And then there's increased risk of drug interaction. So the HAS-BLED tool, again, HAS-BLED is hypertension, abnormal renal function, S, stroke history, B, bleeding history and predisposition to bleeding, L, labile INRs, E, elderly, D, drugs, HAS-BLED. So that acronym allows you to try to remember the parts of it. And again, just like with the CHADS-VASc, each of them are 1 point. And so you add it up, and it gives you an interpretation. And if you exceed 3 or more, right, then you may need to stop. You may need to consider what you can to remove the risk of bleeding or have a discussion with the patient. Now, I've had patients that technically warrant anticoagulation by all other circumstances, but because of another factor, or the patient doesn't want to have that risk of bleeding, I've not used it or initiated or seen it used in a patient population. And so that becomes very relevant for you to not only document, but also to have a conversation with the patient. Now, when we talk about anticoagulants, what are we talking about? Well, in the outpatient, chronic is different than the acute. In the acute, we may use things like low molecular weight heparins, unfractionated heparin. Yes, we can use some DOACs in the acute, but really we're probably going to a parenteral agent, especially if we're having to do something more urgently. But we're talking about our DOACs, our direct oral anticoagulants, okay? And now there are some considerations that you want to be aware of. Really, what we're talking about, talking about mostly the factor Xa inhibitors like apixaban and rivaroxaban in particular. You know, the direct thrombin inhibitor, dabigatran, is probably not one of the preferred agents in many patients. You're going to see more of the rivaroxaban, apixaban options. There is a parenteral factor Xa inhibitor known as fondaparinux, but it's an injectable. Okay, you could technically use it as an outpatient, but again, most people don't want to carry around needles. And then the vitamin K antagonists. Don't forget about warfarin. It works. It's just a pain in the butt. A lot of drug interactions. There's pharmacogenetic factors to cytochrome P450-2C9 and vitamin K epoxide reductase inhibitor. Vitamin K epoxide reductase. There are genetic variations that influence the way it works. And so you'll see fluctuations. But once you figure out the dose for the patient, as long as they don't change their diet and their meds don't change, they can be relatively stabilized on warfarin. And it is a cost-effective option in those situations. Yes, it's frustrating to have to get INRs, PTs, and these things to monitor them. But there's now even point-of-care tests that help patients do that. All right, so you have options, but you need to keep those in mind. What about those non-pharmacologic treatments we were talking about? Remember there was catheter ablation, that was part of the staging and evolution, one of the stages. Ablation, we consider these in patients who are typically younger, less comorbidities, not always, but they tend to do better. If it's utilized earlier in disease, it can significantly reduce the risk of progression to that permanent AFib. And then lastly, there's what is called a left atrial appendageal occlusion, LAAO. And basically, there's a device that includes the part of the inside the atrium and this where the appendage is in that area. It's kind of weird looking and interesting, but it reduces the need for long-term anticoagulation. That's a big deal. That's a very big deal. Okay. All right, guys. So let's now wrap this up and let's pull everything together here. Okay. So AFib with RVR is one of our dreaded things that we see in patients with acute, right? The pulse goes up, they can become hemodynamically unstable. We need to be aggressive at trying to get them under control, whether that's with rate control versus rhythm control. If we're going with rhythm control, we need to consider that duration member and the risk of throwing a clot, right? If at all possible. Once we get them stabilized, we need to consider what is our outpatient, what's our chronic management for this patient based on their comorbidities, presence of structural heart disease, all of those things, presence of WPW, right? That influences our approach to management. And then as we consider rate and rhythm control, side effects, comorbidities drive most of that. And so that becomes really important, right? And then lastly, the need for anticoagulation, both in the acute as well as chronic, using tools like HAS-BLED can guide us. So I hope you found that disease state not only comprehensive, but clinically relevant, and also pulled some things together for you guys. All right, take care, guys.